This is troubling for a number of reasons. First, it's hard to imagine anyone at the frontier of technology or healthcare using fax machines still. But so if that's the case, then clearly that's where we are. Separate to that, though, isn't it, just a missed opportunity and a massive scale for early detection, for tying together what happened to you in one country with what happened to you later. A lot of people move around now, even if they don't. Sometimes they don't have access to the same clinic twice over a long period. So their ability to potentially catch something early doesn't seem helped by this. So, what does this all mean? Is it, in a sense, cutting short opportunities for human health? Welcome to the Health Beats podcast, brought to you by the inaugural Abu Dhabi Global Healthcare Week. The Health Beats podcast series is your window into global healthcare industry news, making headlines, and the role of Abu Dhabi and the UAE in unlocking global healthcare momentum. We give you an insight into the future of the global healthcare sector and Abu Dhabi's contribution to it. I'm your host, Lara Satrakian, and in this week's episode, I'm joined by Dr. Videha Sharma, Clinical Innovation Lead at the University of Manchester. Our conversation today is entitled Precision Medicine, From Hype to Reality. Dr. Sharma, welcome to the podcast.
Hi, Lara. Great to see you. Thank you for having me.
So tell us a little bit about your background and what you do in healthcare innovation.
Sure. Thank you. So I'm originally from the Netherlands. I grew up in Rotterdam, a hardworking port city, but moved to the UK to study medicine. I qualified as a doctor in 2011 and really pursued a quite traditional clinical career. I was training to be a transplant surgeon. But as I progressed through my working life, I very quickly realized that we were increasingly using technology as part of our work, though I didn't really understand much about it. So wanting to learn more about this, I pursued a PhD in health informatics. And that was really an eye-opening period for me because I loved being in the hospital. I loved working as a physician. I loved the patients, the operating, but I didn't really know or understand much about the world outside. And during this period of research, I was exposed to professionals from different disciplines, designers, developers, people working in technology and other fields. And that really made me realize, gosh, there's a whole world of people out there that are trying to contribute to healthcare that I've never even been exposed to. So that period of time really made me reflect upon what I wanted to do in my own career. And I was lucky enough to be selected for a number of fellowship programs. So I did a fellowship in digital health, a fellowship in clinical leadership, and then one in entrepreneurship as well. And all of those experiences made me realize that I really wanted to pursue a career at the intersection of health and technology. So now I'm the clinical innovation lead at a health technology institute at the University of Manchester. And I run a portfolio of projects mainly aimed at putting new and emerging technologies into practice. So I love the final part of that research translational pathway. We've done the science, you've done the research, now let's get it in front of patients and clinicians.
Informatics, precision medicine, all very interesting. Can you explain what they are and what are their uses? How do they really change the lives of the patients you see?
Sure. So healthcare today is a digitally enabled endeavor. So every part of clinical practice is underpinned by information technology, whether it is the data recorded on your smartphone that you're maybe giving your physician to tell them about how your health has been whilst you've been going about your daily life, or whether it is the notes that the physician is making during a clinic visit, or indeed how your diagnostic results go around a healthcare ecosystem and provide insights that allow your treatment decisions to be made. So information technology underpins everything that we do in healthcare, yet it is also extremely complicated because healthcare, as compared to other domains where information technology plays a big role, the common comparator that people use is banking, which is also today a digitally enabled industry, as opposed to traditionally where you had bricks and mortar banks. Now people bank on their mobile phones or online. And though there are some similarities and lots that we can learn from other industries, I think healthcare is intricately complicated. It's about humans, it's about health, it's about feelings, it's about emotions, and it's far more difficult to therefore really develop solutions that meet the needs and requirements of such a complex endeavor. And informatics is really the field that tries to better understand what needs and requirements are, both from healthcare professionals and patients, and try to come up with solutions that meet those needs and requirements. So I really enjoy thinking about that because I am not traditionally someone who is particularly tech savvy. My wife always makes fun of me having an old phone and never having the latest technology. But what I do love is I love people. I love how people interact with technology, or how technology allows them to be more independent, maybe have more personalized care. And that's really where the transition to precision medicine, I think, comes in for me. So the part of precision medicine that I work in is around the idea that we all respond differently to medicines. And a big part of that response is determined by our genes. This is something that we've known for a long time, and the science behind this is called pharmacogenomics. However, we don't really apply this in clinical practice on a daily basis. So if we were to be able to test for these genes, then we could say, gosh, you are unlikely to respond to this medicine. You're better off with this alternative. And despite having known the science and the science being mature, we've not really been able to put this into practice. And that's really where I think the intersection between that personalization and precision medicine comes in, because it requires digital and data infrastructures to realize that. And that's what we've been working on the last few years.
That sounds fascinating, and it sounds huge. If you know that your genes make you more likely to respond well to a certain course of treatment, I mean, don't you just want to take that into the doctor's office with you on day one? And how far are we from that reality?
Yeah, great question. So I think in certain niche use cases, we're quite far ahead. So for certain cancer therapies, there are specific gene changes that we know are mandated in the United Kingdom by something called the NICE, the National Institute for Clinical Health and Care Excellence. They mandate that certain prescriptions have to have a gene test before commencing. But the place where we think the greatest...
So that you know that it's effective, or so that you avoid... I mean, what is that? I mean, that sounds very smart. I wish every government would do that. Is that to make sure that you're getting the right treatment, or to avoid any adverse impacts?
That's right.
What led to that?
So I think it's both. So I think it's about making medicine safer, so avoiding adverse events. That's true for some medicines. So I think for the chemotherapy agent, that is the particular driver. But for other medicines, it's also about making them more effective. So, for example, a common blood thinner, clopidogrel, that's prescribed after stroke, helps keep the blood thin and avoid recurrent strokes. We know that a proportion of the population do not respond to this medicine. It's ineffective for them. So giving them this blood thinner does not mean that you're actually reducing their chance of having another stroke, and they are having the same risk as someone who is not taking that medicine. So there are different use cases about the safety as well as the effectiveness of medicines. And I think this is the part where, though it sounds great globally, there are nuances and there is detail, and you need to have expertise both in the genomic space, but also in the implementation space to understand, well, for this particular use case, this is important, this is how it's prescribed, these are the prescribers, and this is the part of the workflow where this needs to be introduced. So it's both those elements.
Is it universally available to doctors everywhere? I mean, how you hear often this expression, the future is here, it's just not equally distributed. So in the UK, in some cases, what you know about your genes can help you get better cancer treatment. Is this the case everywhere? And what does it take for this to become the case in all disease areas?
Sure,
I think also people might find it a little surprising. You can do 23andMe, you can do all these tests. There's so much you can learn. I mean, you don't want that to be disconnected from when it really counts, when your health is at stake.
Yeah, absolutely. I think that's a really good point. And I wonder whether we're going to see a general shift. I think 23andMe and the Ancestry solutions have provided some insights to people, or helped answer questions of curiosity, perhaps, about their heritage, etc. But I think we're going to see a shift where we say these genetic tests, whether they're consumer-based or indeed provided through healthcare organizations, should really make a shift to not just provide interesting information, but valuable information that's going to change your health and well-being. So I think that's going to be a shift that we're going to see various predictive statistics around market size for consumer genomics predict that it's going to be a rapidly growing industry. But I think the shift is not going to be in more people wanting to find out more about their lineage, but it's going to be about, gosh, what can I actually find out in my genes that's going to help my treatment? And within that space, again, we want to be, I am, of course, also a researcher, a scientist by background. So though I'm extremely enthusiastic and positive and optimistic that we should be doing this, we also need to be do this carefully, right? So we want to be introducing tests and solutions for which the level of evidence is high. So there is an international organization called the Clinical Pharmacogenetics Implementation Consortium, or CPIC, and they publish guidelines, and members of our team work with CPIC to help write these guidelines. And for example, in the UK, we would only want to implement diagnostic tests, pharmacogenetic tests, for which the level of evidence has reached a sufficient level, so we can say, we can give you this advice with confidence.
Now, you've devoted your life to this idea that technology, data, and your digital health management can be a game changer. It's transformational. So what is the state of play now in terms of digital health and data, the use of data, and where does it live? Essentially, is it stuck with our healthcare providers? Can an individual now own their own essential health data? Or help us understand the map.
Sure. So I think, speaking from a European and maybe even more specific UK perspective, in some ways we are advanced. We have digitized healthcare records at scale. So most primary care practices or secondary care practices will use electronic solutions, electronic health records, electronic medical records, whatever you want to call them, to manage your healthcare journey as part of your health experience. I think where the biggest gap lies is in this idea of being able to exchange information between different systems, different care settings, different providers. This term is often described as interoperability, the ability for computers to share information with each other in a meaningful way. And I think globally, we have not succeeded at that well. There are some examples of people that, of locations, geographies that have slightly progressed. The UAE, and I think Abu Dhabi is an example. I often read about Malafi during my PhD research, which was exactly on this topic. But certainly in the United Kingdom and in Europe, we still struggle with this at scale. So as a physician, I still, the classic example that I always give, the reason why I started off on my career in digital health is because I was training to be a transplant surgeon. And as part of our transplant evaluation process, as a specialist center, we receive referrals from across the region. But we would receive these as paper letters, as fax documents, as PDFs attached to an email. And we would, print them out and hold them in our hands and then manually transcribe something onto an electronic system. Because none of the electronic systems met the needs and requirements of the transplant unit, we just use Excel files to manage our patient lists. And that's something that is widely ubiquitous. So I did a national survey of all the 23 transplant centers in the UK as part of my PhD, and these practices were replicated across the board. And that's because, like we said earlier, healthcare is complicated, right? And it's difficult to make digital tools and solutions that can meet these nuanced requirements. And with that, I think healthcare providers, so not wanting to put the blame in one camp at all, I think also healthcare providers have got a single institution perspective. So they look for the needs and requirements within their own organization, but they don't, as a result, fail to realize that healthcare, the individual patient, is not just going to visit their organization. They're also going to visit their GP. They're also going to visit other clinics and other healthcare settings. So being interoperable should be part of the design. Yet in reality, it is often an afterthought. So an electronic medical record is implemented. It might improve the workflows, might improve the efficiencies within that organization, but it does nothing for moving information around a disparate healthcare ecosystem. And patients do not have their care in one institution today.
This is troubling for a number of reasons. First, it's hard to imagine anyone at the frontier of technology or healthcare using fax machines still. But so if that's the case, then clearly that's where we are. Separate to that, though, isn't it just a missed opportunity at a massive scale for early detection, for tying together what happened to you in one country with what happened to you later. A lot of people move around now, even if they don't. Sometimes they don't have access to the same clinic twice over a long period. So their ability to potentially catch something early doesn't seem helped by this. So, what does this all mean? Is it, in a sense, cutting short opportunities for human health? And you build technology on top of data, of course. So what more is possible as we start to see that interoperability and this longer arc of a person's health history, hopefully secure, privacy guarded, all of that. But this seems like ripe for disruption or reinvention or both.
Absolutely. So
you're smiling. I think this is the first time it's been pointed out.
What you're referring to, I think, is we need to get the foundations right, which we haven't quite got right yet. And there's lots of excitement about the potential of digital health, AI. We haven't even touched upon that yet, but that's obviously a topic that's thrown around a lot. But certainly in my experience, the foundational level of digital implementation and interoperability is what really will drive the impact that more emerging technologies will have. So that's really where I think there is lots of scope for disruption. However, in reality, it is also extremely challenging because the market, certainly in Western Europe and certainly the States, is had the largest amount of the market share is taken up by incumbent organizations or incumbent providers that are potentially so large that it is hard for new entrants to really disrupt that in a meaningful way. And again, as we said earlier on, healthcare is about data. So as an organization commits to a electronic healthcare record provider, say they committed to that 5 years ago, that is a huge undertaking. It's an extremely expensive procurement. And together with that, you've now got all your data locked in, or siloed is the kind of phrase that people use, within this one enterprise solution. So if you now want to switch that data migration process, because you can't start from scratch, like you said, you want to keep a patient's record for life in theory, and you want to be able to manage their health longitudinally, so you want to migrate that data, that's really hard. And to kind of add to that, often these individual providers, these vendors will use different standards the way they store data. So it's not like it is one way that data is stored. So even something simple as a data concept such as blood pressure will be stored in one system in a certain way, another system a different way. So that migration every time is not seamless. It requires translation, it requires costs, and as a result, data is also often lost. So, I love the notion that you described of having that data with you for life. And that's exactly the kind of vision that we believe in. We call it a patient-centric record for life is the kind of phrase that we often use. But in reality, within the environment, the ecosystem that we have now, it's really difficult. But I will say, and this is, I think, why I got particularly excited about the precision medicine, the genomic space, is for clinical areas that have not been subject to 20, 30 years of this kind of legacy silo approach. There is more opportunity. It's more of a green field to start off right. So again, the phrase that I've been using is...
Are these specific disease areas? Yeah. But is this because they're new disease areas or because they're... Yeah.
I think it's perhaps new disease areas. It's also maybe areas where we perhaps haven't recorded data in the same way in the past. So, for example, the common ones are genomics and precision medicine. I think is a great place. We haven't got 20 years of genomic test results locked up in all these different silos. So we can try to do that. We can be interoperable by design as we come up with the infrastructures to support genomics. The other places are things which they're on the fringes of kind of core healthcare. So we are now increasingly realizing that it's important to talk to patients and ask them about their wishes. And patient-reported outcomes are becoming increasingly popular, and rightly so, because how people experience healthcare has a significant impact on their health outcomes. So it's not just their experience outcome, but also their health outcomes that are impacted by their experience. So being able to record those, people are starting to do that in an interoperable by design way. And that really comes down to the use of data standards. So there are a number of standards out there. I think some of them are more mature than others. The ones that we have been working with is a standard called Open EHR or Open Air, which is an open standard. And the other one that we commonly work with is something called HL7 FHIR or Fast Healthcare Interoperability Resources. And these are all open standards. They're published openly on the web. So if you use that, that means that if anybody wants to interact with you, they know what the data specification is. The costs for integrating through open standards is much lower compared to if the standard is closed and you have to pay the vendor to say, hey, we want to have access to your data. Sure, you can. Here's the bill. So you want to try to bring those costs down. I mean, this is maybe an unpopular opinion that people that make health IT software may not like, but I think from a patient perspective and from a government or implementation perspective, that's really what we want to see.
That sounds great. I think you're so empowered. You often hear that data is empowering. In this case, it's your own data, your own genomics. How does that data interoperability play into scaling new innovations across health systems? What can you create with it?
Great question. I think this is exactly where we've failed in the past. So healthcare is delivered at a range of care settings. However, our infrastructures have not supported that in the past. So I can give you the example that we've been working on recently, which is trying to make precision medicine a reality in primary care. So as we said, our genes determine to a certain extent how we respond to medicines. And this is something that's been known in the scientific or the genetic community for a long time, but prescribing and medicines don't happen in a genetics clinic. They don't happen in a laboratory. Prescribing happens out there in the community, in primary care, in pharmacies. That's where medicines happen. So how do you bridge that gap between those genetic laboratories and these primary care settings? And as you said about scale, you could approach that to say, hey, there is a primary care practice, a family practice in this place that wants to work with us and wants to pilot and try this out. We will send them the information and we'll make what we call a point-to-point integration between our lab and this clinic, and they can have the results when needed and they can personalize the prescribing for their patients. That works well if you're only trying to do one integration, but there are hundreds, thousands more GP practices just in England or the UK alone. So that point-to-point model works if you're integrating once, twice, maybe thrice, but after that, that starts to fail. So we need to, what we describe, separate the data from the application. So the data is stored in a vendor neutral or perhaps agnostic. These are kind of terms to describe that the data is held centrally in a way that anyone can access. And the reason why everybody can access it is because like we said before, the specifications for how the data is stored are published openly. The data is held securely in a modern cloud environment, but the specification of how that data is stored is published openly. So you can say, if you as a family practice or you as a hospital or you as a specialist center want to have access to this precision medicine data, here you can come and get it. And here are the specifications. And this is how you can integrate. So you lower those costs for integration and you make that data separated from the individual application. So we've said, as we started rolling this out, we have had hospitals and electronic medical record providers say, yeah, sure, send us the data. We're over here. We'll do everything. If you just send us the data, we'll do the decision support and we'll make the reports. And we said, well, as lovely as that sounds, that's not our strategy. We're going to keep the data in a central place and you can come and get it when you need it rather than us sending you each individually the data. So I think that separated or decoupled architecture, something what they sometimes call it, is I think how increasingly we will be able to have scalable solutions.
So a lot of things come to mind when you talk about this. First, of course, who owns the data? Right now, it's with our providers by and large. I'm an American, as you can hear. So in America, at least, it sits with a lot of hospital systems. As you said, it's hard to port it over. So how do you build a relationship with your own health data? How do you sort of consider, and how far are we from that? You talked about this. Is this theoretical? Is this right around the corner? Is there a lab you can go get right now where you can see all this in one place and take it to different vendors? And do vendors know what to do with it? How far are we from it being able to implement this with real clinicians who would see that data and understand, here's what's going to be right for you from a precision medicine standpoint. This is how we're going to treat you based on your unique profile.
So I think you're absolutely right. Because it's so difficult to move data around healthcare ecosystems, various geographies have decided, you know what, let's just give it to the patient. The patient themselves moves around and they are the portable aspect of our healthcare system. So let's empower them with the data. And I think that's a very fair strategy. So, for example, colleagues in the Netherlands did this around precision medicine specifically, where if you were tested for your genes to check your response to commonly prescribed medicines, you were given a physical card, a little card that you could keep in your wallet. And when you turned up at your doctor or if you turned up at your pharmacy, you could say, hey, here are my test results. For this gene, I'm so-and-so metabolizer, and therefore, if you're going to give me this medicine, it needs to be higher or lower dose or whatever. And as rudimentary as it sounds, and in our kind of technology-enabled world, it sounds maybe very backwards to give people a physical card. In terms of making things happen and actually realize the potential benefits of precision medicine, you're actually achieving those, right? So from the kind of designer in me would say, solve the problem. And you may not be the best way of solving that problem, but at least you're solving it, as opposed to not understanding the problem and coming up with solutions that don't actually allow you to move that data around in the first place. So giving the patient a physical card, I think, is perhaps rudimentary, but it does achieve something. The kind of next step to that is, could you give them some kind of app that they could use? They've got it on their phone digitally. Of course, that has a number of advantages to that. And then in the UK, we have, of course, a centrally commissioned National Health Service, and we have something called the NHS app. So all citizens have access to an app through their single NHS number, and in that app they have various aspects of the health record which are centralized. So their recent prescriptions, sometimes letters from their general practitioners. So it is good at giving the power to patients around their primary care data. What we are not very good at is things like hospital data. So if you have a more complex health journey, that is much more difficult to manage. Having said that, I don't think that's necessarily a bad thing, because if you have general health challenges, they can be perhaps solved by a general, more broadly used solution. So the NHS app might work for your allergies, for your prescriptions, for something like precision medicine reports that are used in different care settings. But if you, God forbid, have kidney disease, kidney failure, and require transplant, perhaps you need a specialized app to manage that journey specifically, that is actually tailored and designed for people with kidney disease. Or if, God forbid, you have vascular disease and you need to have treatment for that, and you end up with an amputation, say, you again want to have a specific app that meets those needs and requirements. Maybe it creates a community for other people who've also had amputations, and that allows you to communicate with other people who've had similar experiences. You build a community. So for each needs and requirement, there needs to be specific solutions. But underlying that, what we would love to see is that the data that feeds these different solutions, this goes back to that idea of separating the data from the application. We'd love for all these different solutions to be fed by data based on open standards that is stored centrally and securely. And I think that's the kind of model. So EY published now a good few years ago a great report which kind of described that, moving away from these individual enterprise solutions to this health data ecosystem where data is held either centrally or federated, but it's all held based on open standards. And then you can have folks who are developing solutions which are patient-facing or clinician-facing that really deeply understand the needs and requirements of those end users and therefore bring benefits at scale. And that's the kind of ecosystem we'd love to see.
What else are you excited about? What are you most excited about when it comes to the future of innovation in healthcare?
So I think what I'm excited about is I'm increasingly seeing colleagues, both clinicians as well as researchers and academics, as well as entrepreneurs, who are trying to bridge that gap between what we think about, our ideas, our research, our projects, our pilots. We love to do pilot projects and trying to bridge that gap into implementation at scale. So I think trying to think about the data, trying to think about end users, trying to think about your diverse communities that you're trying to impact, that's happening more and more. So certainly a personal, I suppose, mission of mine is to continue to educate colleagues to say, it's great if you're doing this research, you're great if you're working as a clinician and you want to come up with a solution for your individual problem, but try to think bigger, because the problem that you're facing, there's likely someone else that's facing the same problem somewhere. So how can you be more collaborative in your innovation? How can you be more communicative? And I think a big reflection that I've had is that certainly as academics or scientists, we've historically been poor at communicating. We love to write research papers and use big words and be very clever and all the rest of it. But really, we could all benefit from I could definitely benefit from being more humble. I don't want to talk about anybody else, but I could benefit from being more humble and say, I want to communicate more in an open way. I want to use the language that everybody can understand, and I want to communicate my ideas at scale, as opposed to these kind of isolated communities, these little silos that we love to live in and be very smart in. So that's really something that I've been working on. And the only way to do that is to really put yourself out of your comfort zone, right? So for example, a great experience that I've had over the past 6 months or so is that I've been working with a creative director and a brand strategist who has got no health background at all, but she's a great communicator and she's a visual thinker. And she's really helped me think about how I communicate, how we as a scientific community can communicate. And I think that shifts the needle. It helps people understand what you're trying to do, and it helps bring impact at scale.
Thanks for listening to this episode of the Health Beats podcast. For more healthcare industry news, visit the Abu Dhabi Global Healthcare Week newsletter. The link is in our bio. And if you're interested in meeting me and our guests in person, join us at Abu Dhabi Global Healthcare Week. It's happening May 13th to 15th at ADNEC Abu Dhabi in the United Arab Emirates. Thanks for listening. Like, subscribe, and continue to follow Health Beats by Abu Dhabi Global Healthcare Week for your global healthcare industry digest.